Hello, everyone, and welcome to the Sarcoma Foundation of America's first Subtype Series education session of 2025. We're excited to resume this series this year with this afternoon's discussion of chondrosarcoma. My name's Christy Arishjan, and I'm the Program Manager for Engagement and Research at SFA. I'll be serving as your host and moderator for this panel discussion. We thank you for taking the time to join us for this important conversation. Before we begin, I'd like to briefly go over the format and logistics for today's discussion. We have two panelists who are experts in the care of people with chondrosarcoma from two sarcoma centers here in the United States. Also joining us is a sarcoma patient sharing his experience navigating life with chondrosarcoma. Following an introduction by James, we will open up to a panel discussion. At any time during today's session, you can submit your questions by entering them in the questions and answers field at the bottom of the screen. I will then share your questions with our panelists. Please do not use the chat function to submit your questions. Remember, our panelists will not be able to answer questions related to your specific medical situation, so make sure that they're related to the topics raised during the session. Information in this webinar is for educational and informational purposes only, and it's not a substitute for medical advice from your physician or your care team. Today's session is being recorded, and a link will be distributed to all registrants and posted to SFA's website. Finally, as a reminder, all participants are muted. Now, I would like to briefly introduce our panel members. Dr. John Trent is a professor of medicine, associate director for clinical research, and director of the Bone and Soft Tissue Sarcoma Group at the Sylvester Comprehensive Cancer Center at the University of Miami Health System in Miami, Florida. His clinical, educational, and research efforts are focused on GIST, chondrosarcoma, and other sarcomas. His interests include the clinical and translational research of sarcomas, the direct care of patients with sarcoma, and education about sarcoma and patient-oriented research. Dr. Bill Tapp is the chief of the Sarcoma Medical Oncology Service at Memorial Sloan Kettering Cancer Center in New York City. He's a medical oncologist who specializes in the treatment of patients with soft tissue and bone sarcomas. His research interests include understanding the genetic and molecular nuances of sarcoma, identifying and validating novel therapeutic targets, and treatment biomarkers and drug resistance. Both Dr. Trent and Dr. Tapp are active members of multiple national and international sarcoma organizations, as well as members of SFA's Medical Advisory Board. James is a chondrosarcoma survivor and active member of the Louisville, Kentucky sarcoma community, and he joins us today to share his experience. Thank you all for joining us. James, I'd like to hand it off to you to get us started.
Absolutely. Thank you, everyone, for coming and learning a little bit more of something that's affected me and maybe affecting you. So my journey started back in 2018. It was a random happening of fate. I got hit in the face with a baseball throwing batting practice, and it led me to the immediate care center. The immediate care center did CT scans. They showed something there and encouraged me to get an MRI. That was my very first year of teaching. I'm an educator, and it was scary to leave the profession right then and there in my first year. It was like right in the first semester. So I postponed getting that MRI, unfortunately. And in the summer of 2019, I had that MRI after my first year. And it showed that there was a 3.8 centimeter chondrosarcoma at the base of my brainstem. So it was a really scary finding for myself and my family. We were worried about, what would care look like for me? Do I need surgery? What were the questions? We were trying to find the best care possible, and it just so happens to be that I have family in Maryland and ended up going to Johns Hopkins in Baltimore and seeking care there. Ended up having a total of 4 surgeries. 3 of them were transsphenoidal. Of course, the first transsphenoidal going through the sinus cavity was a failure because I live in the Ohio River Valley. And if anybody's ever traveled here, it's nothing but pollen 24/7. So there was a sinus infection, of course. So they had to clear that out. But the biopsy of the second surgery of the tumor showed it was a grade 0, heavily calcified. So I may have had it my entire life. First surgery, of course, was in 2019. The subsequent surgery was in December of 2019 or November of 2019. And then we were postponed to do another surgery, try to get more of the mass out in February of 2020. We did that one, and then I was discharged. And then while I was discharging back home, actually, right when I was being discharged, that's when COVID hit. So it put a halt on everything. And they were only able to, core out the tumor. They really weren't able to remove it all, being that it was heavily calcified and embedded in my brainstem. That they decided that the best course of action would be to do a craniotomy, and that happened in July of 2020. So far, I'm going on 5 years post craniotomy. All my MRIs since then have shown that the tumor has remained stable and hasn't grown, which is great. I do accredit the team that gave care to me, Johns Hopkins University. That's probably a big reason why I'm still here today, is that I had so many experts uh, giving the care that I needed. Also, throughout this journey, since I was in the hospital for so long, I had full muscle atrophy. So I had to relearn how to walk again, had to go through some intense physical therapy, uh, occupational therapy, and I also had to go through speech therapy because I had lost the ability to swallow. Uh, so it really put it felt like the universe kept throwing stones at me. But through the care that I was given and my support team, and the love that everybody was sending me, it gave me the willpower and the grit, pretty much, to overcome anything I could. And in about 6 months of therapy in 2021, about Octoberish, September, Octoberish, I was able to walk again out of my wheelchair unassisted, and of course, regain my ability to interact with everybody in my life. I'm a father of two. Then it was just one. We've added another one since then, and it's a great blessing to have these boys in my life. Uh, but to be able to regain some of my normalcy was probably one of the best things ever. Being in the darkest place while going through those surgeries, it's tough. And if you're going through the same thing, then I recommend that you just hang in there. The universe has a purpose for you, and things will pan out. So, but that's my story. I'm a lucky one. I try to share my story with as many people as possible. Again, I'm a teacher, and at the beginning of the year, I always share my story with my students because I want them to know that tenacity is a trait that you don't have to go through brain surgery to have, but everybody has a little bit of tenacity, and that tenacity will get you through life. So that's it's a brief part of my story, and I'd love to talk about it.
Thank you so much for sharing that, James. I'm sure that there will be more pieces of this that we'll get to hear from you as we discuss more about it. But that's really an incredible story of resilience. So thank you so much for being willing to join us and share that. I do have a couple of questions for you, just to start us off. How much time in total did you spend away from your career when you were diagnosed and going through treatment?
So 2019 is funny because September 11th of 2019 was when my first surgery was. About a week and a half, 2 weeks prior to that, I had my first seizure. And that's when we called Johns Hopkins, let them know, and they said, "Yep, you need to get up here. We need to do surgery," because I developed hydrocephalus, so there was fluid on my brain, and so it was about early September, late August of 2019, whenever I left my current position there, and then I didn't actually get back to teaching until 2022. So it was about 3 years.
Yeah,
Unfortunately, the position that I was in, they pulled it out from under me whenever I was recovering, which that's a different story. But yeah, it took about 2 years to get back into my career, which had just started. Um,
sure. Yeah, it is a different story, perhaps, but not, I think, uncommon for so many folks navigating their own sarcoma journey is figuring out how to balance all of those things and get through. So thank you again for sharing that. Dr. Tapp and Dr. Trent, I have a few questions for you, and hopefully you can share your expertise with us. Thank you for being here this afternoon. Um, a lot of what James has shared, I think, is specific to chondrosarcoma, and some of it is maybe not so specific to chondrosarcoma and is sarcoma general. So my first question for you is, how is chondrosarcoma different from other sarcomas, and kind of what makes chondrosarcoma chondrosarcoma?
Sure, I'm happy to start with that. I mean, I think when we talk about sarcomas, a lot of people just think that it's one cancer. Um, but when we talk about sarcomas, it really represents probably now over 100 different diseases, all of which are molecularly and genetically different, right? So there's tremendous amounts of diversity. And there's a lot of diversity within a given sarcoma itself. And I think chondrosarcoma is reflective of that, where, when we talk about chondrosarcoma, it's not necessarily one disease, and it's definitely not one presentation, right? So you really have to think about the individualized. And I first would like to thank James to, tell his story and to share that with us, because I think it highlights how every person is an individual. Chondrosarcomas are cancers of cartilage, right? And cartilage is looped into kind of the bone cancers that we deal with, and it's exceedingly rare, right? So probably only a few hundred people diagnosed in the United States each year. And when we think about chondrosarcoma, we think about several different types. Most people are diagnosed with what we call a conventional chondrosarcoma, and we generally grade them based on how cellular they are under the microscope. And so, the earlier grades tend to have a lot of the cartilage within the tumor, like so the cartilage matrix that often surrounds the cancer cells, and that explains why many of these tumors are resistant to different therapies. As the grade gets a little higher, so when you go from grade 1 to grade 2 or to grade 3, they become more cellular and a little bit more aggressive. So grade 1 chondrosarcomas are thought to generally be localized tumors, and there's been some shift in the nomenclature of the tumors, where sometimes when we see lower grade 1 chondrosarcomas in the extremities, they're now given the name ACTs, which are atypical uh, uh, chondro tumors, right? So a little different than what we say when we talk about the grade 1 tumors. But aside from the conventional chondrosarcomas, there's also dedifferentiated chondrosarcomas, which can be very cellular tumors and genetically complex tumors. There's mesenchymal chondrosarcomas, and then there's a rare version too called a clear cell sarcoma. And there are tumors named extraskeletal myxoid chondrosarcomas, which are actually not chondrosarcomas, we think, right? So there's a lot of confusion there. So first of all, understanding which of the type of chondrosarcoma you may have is very important. And within all of those categories, there's a lot of heterogeneity and a lot of diversity. And what's really important is how the tumor presents within a person, right? Because that often will dictate the type of symptoms they have, the type of therapies they need, the type of physicians they will need to see. And that adds this layer of complexity. But anyone dealing with it really needs to understand that it's important to be surrounded by physicians who not only understand the disease chondrosarcoma, but how it's affecting you, right? Because that's really important in coming up with the right treatments for that. So I wanted to give a little overview before John put his camera on, and then I'll see if he has any other thoughts or comments with that as well.
Yeah, it's really great to be here, and I'd like to thank SFA for hosting this event. These types of events are really critical, especially for rare diseases. And I'm, as with the other panelists, I'm delighted to be here. And thank you, James, for sharing your story. It's really, really remarkable. And I would echo everything that Bill said. And I would just also add a few points. One, and Bill and I deal with this all the time, but you have to get to a sarcoma center. James ended up at Johns Hopkins, and it's a great sarcoma center. They have great pathologists. The reason I'm bringing pathologists into it is having a sarcoma sample reviewed by an experienced sarcoma pathologist is really foundational. It's really the first step of the journey. It's where all of our decisions arise. Bill listed all these different types of chondrosarcoma: conventional, mesenchymal, clear cell, all of these different entities. And everything that we do medically, our decision making is driven by what type of chondrosarcoma it is. Conventional chondrosarcoma might be treated with surgery first. If it's a mesenchymal chondrosarcoma, we might in fact use chemotherapy first. And so this is really two different scenarios. And then the grade is critical. A grade 3 chondrosarcoma is vastly different than a grade 1 or a grade 0 or an ACT, as Bill mentioned. So first step is really experienced sarcoma pathologist has to review it, make the correct diagnosis, and meet with a multidisciplinary team at a sarcoma center so that we can set up a path, set up a pathway to give every chondrosarcoma patient the best opportunity for cure that there is. And this is best managed at a multidisciplinary experienced sarcoma center.
So thank you both so much for those great answers. You have both touched on a few things that I already wanted to ask. It sort of set me up for that, so thank you. I'm going to go ahead and start with one of the things that Dr. Trent, you just mentioned. So you mentioned that the different subtypes of chondrosarcoma may, depending on what type you have, it may change the approach to treatment. For example, the order in which you would receive, medical intervention like chemotherapy versus surgery. Is there consensus on how that might be done among general sarcoma specialists? And what are the different approaches that may be taken depending on the subtype of chondrosarcoma that a person may have?
Yeah, those are great questions. And depending on the subtype, the diagnosis really helps us determine the treatment. That's the first step. And then discussing it with our multidisciplinary colleagues. So our sarcoma centers have experienced sarcoma faculty and staff and nurses, pharmacologists, nurse practitioners, and this whole team helps figure out the optimal treatment. And so the diagnosis is critical from the pathologist, but then also the radiologists also help with the diagnosis. Is it an extraskeletal tumor or a skeletal tumor? That can be a big difference. And what bone is it arising from can be critical. And then once we understand anatomically and pathologically, then we work with surgeons to understand what surgery would be required to remove the tumor as a whole with a rim of normal tissue, which would be an appropriate sarcoma surgery. And as in James's case, it might require a neurosurgeon. It might require an orthopedic oncologist. If it's in the pelvis, it might require an orthopedic oncologist working closely together with a surgical oncologist who's used to working of the soft tissue in the pelvis. And so the multidisciplinary team is really, really, really critical. And there's, it's a critical first step for us to all work together and make sure we administer the optimal therapy for the patient.
Yeah, I think I would agree 100% with what John said. In general, certain chondrosarcomas, like John mentioned, the mesenchymal chondrosarcoma does often include chemotherapy. We usually will treat that along a Ewing sarcoma type of paradigm. The dedifferentiated chondrosarcomas also often usually entail chemotherapy and are often treated along an osteosarcoma paradigm. I think we still need to understand that a lot better, especially when we talk about treating a tumor through a different paradigm. The timing of the chemotherapy is very much has to do with that multidisciplinary approach and understanding surgical options and what are the goals of chemotherapy. But there are tumors that have a higher likelihood of spreading to other parts of the body, and the chemotherapy is there not only to protect people but also to potentially help facilitate surgery. I'll also say that a lot of the conventional chondrosarcomas, especially the early ones, are often surgical diseases. So, many times the treatment when it's primarily bone located is going to be dictated more by the orthopedic oncologist who understand where they are in the bone and what type of surgery is needed, and that's critical because the orthopedic oncologists really understand the anatomy and they understand these tumors exceedingly well. But I agree with John too that so much of it has to do with the nuance of where the tumor is presenting and then where it is, how it's affecting an individual and what type of surgeries are going to be needed. There's been a lot of work. John's done a lot in his lab understanding the genetic nuances of the tumors too, right? So we hope that by having better understandings of the genetic basis of the tumors, that it may also open the door to different medical managements and when that can be used for patients, right? So that's critical. And I'll also mention there are certain forms of chondrosarcoma that are hereditary. So they can actually develop because of genetic predisposition syndromes. That patients can have benign lesions that turn into the chondrosarcoma. So understanding those are very important too, because that may require, again, genetic counseling and different teams that are involved in patient care.
Could you expand on that a little bit? What kinds of genetic predisposition syndromes should people be aware of?
Well, there's definitely ones that have mutations in IDH1. So IDH1 is a gene that we know can often be mutated in many types of conventional chondrosarcomas. The literature has anywhere from about 40 to 50%. We can also see that in the dedifferentiated chondrosarcomas. We think that it's a gene that's mutated early on in the development of chondrosarcomas, and you can see that in certain benign lesions such as enchondromas, right? So there are patients with hereditary enchondroma syndromes that, some of the enchondromas can develop into chondrosarcoma. So that's one of the primary ones.
Yeah, so there can be an IDH mutation that's in the germline, kind of like BRCA, or you've heard of BRCA, or the breast cancer syndromes. There can be rarely an IDH mutation in the germline, so that it's mutated in every single cell in the body, but it seems to really only affect bone. And so the two most common syndromes are Olliers disease and Maffucci syndrome. Those would be the two most common. And they're usually manifest with, like Bill said, the enchondromas. And there would be some bones growing really short, not fully developed. So it's very apparent. So if for people that are affected or their loved ones are affected by chondrosarcoma, when it's hereditary, it's very apparent. There's really no doubt. It's not something you have to rush out and get tested for immediately. It's something that would be apparent from the time of diagnosis.
Great, thank you. I actually have a question for James as well. This is sort of two two-part. One is, how did you know to go to a sarcoma center or to go to a place like Johns Hopkins? Because it obviously was quite far from where you live. And that's something that Dr. Trent and Dr. Tapp have both touched on. So it'd be helpful to know.
So it really wasn't our first thought. We explored local care, University of Louisville and Norton's Hospital, and their neurologists, they really didn't have any experience with the location of the tumor. They thought it was a different type of tumor because it was close to the pituitary gland.
Wow.
But we were trying to find the best care. And I still vividly remember my wife and I sitting in one of the neurosurgeon's offices, and she said, I don't care what it takes. It's not like it's your shoulder or anything. This is your brain. We need the best. And the surgeon recommended, places that specialize in different types of tumors, like this chondrosarcoma. We didn't know it was a chondrosarcoma at that point, like Johns Hopkins. And like I said earlier, my sister, she lives in Baltimore. She lives right outside of Baltimore. So we had a connection there that would have made us feel a little bit safer. Made us feel like home, because we knew it was going to be a long road. We didn't know it was going to be almost 2 years long, but we knew it was going to be a long road. So ultimately, the choice was, go to somewhere that felt familiar. Baltimore being, or Maryland, the state of Maryland being somewhere that we've been multiple times, and go to somewhere that had the ability to give the appropriate care.
Right.
So that's why we chose Johns Hopkins.
It's interesting because it sounds like, and this is obviously my interpretation, but it sounds like the unfortunate in your particular case, but also on the flip side, somewhat fortunate
Absolutely.
stance that your tumor was in such a vital location made you immediately seek out really, really specialized care. And I'm wondering if the whole panel could kind of speak to the fact that in the reality is that that's not always the case with all sarcomas, and certainly not all chondrosarcomas. And if there's thoughts on how, we could approach that problem.
Yeah,
So for example, like James said, it's not like it's in your shoulder. Well, it may be for some folks.
It's sarcomas are very complicated. We know there's at least 175 different types, if not more. So it's very complicated. And honestly, delays in diagnosis are common and something that we see all too frequently. There's some data in the literature that's been published showing delays up to a year or longer, even from the first symptom to the diagnosis, or even from the first time they enter the healthcare system until they get their treatment started. And so, so it's something that we see. We also see misdiagnosis. The initial chondrosarcoma is also complicated because there can be a chondrosarcoma that might have some features of bone, but there can be a bone cancer called osteosarcoma that might have some features of cartilage. And so it can be very complicated to diagnose, even for us. Sometimes we have a hard time, and it's not unusual that I send Bill and some other colleagues an email and say, hey, what do you guys think about this situation? Or our pathologist might do the same thing to make the correct diagnosis. So it's very complicated, but getting to a sarcoma center is worth the time and the investment and the travel, in my opinion, to get the right diagnosis and get the right treatment started.
Yeah, I would agree wholeheartedly with what John said. I mean, I think always the hardest thing with a rare disease is to get the diagnosis, right? And a lot of these tumors also affect younger people, where they may not have the symptoms either taken seriously or really evaluated as quickly as some other people. So I think it is a big challenge. I will say though that one of the good things about sarcoma is that it's a really tight international community, and it's not only tight within the sarcoma centers and the treating physicians, but also the patient advocacy groups like SFA, Chondrosarcoma Foundation. And so there are tremendous networks out there to help guide patients. And, most people will also help weigh in, as John mentioned, to think about best care paradigms. So I would agree that, getting the diagnosis is hard and there are often delays, but when you have the diagnosis, there is, a lot of ways to get connected into centers that know, support groups that know, and really can help guide you, right? And in diseases like chondrosarcoma, it's not only medical management, surgical management, there's, a lot of physical therapy, ancillary types of treatment, supportive care that's needed to understand the research that's going on. So there's a lot of people that you can really put together around your care team. And some of them may be local, some of them may be, at centers of excellence that are a little further away. There's pathology review. So these are all the critical aspects of it. But we are a tight community, and I think everyone is really willing to help. So that's the important thing. So there is help out there. It's just how to really get connected to it.
That's really helpful. Thank you. This is sort of related, but and each of you have kind of mentioned this tangentially, but I think it would be helpful just to clarify, what are some examples of both malignant and non-malignant conditions that you have seen as common misdiagnoses or differential diagnoses when dealing with chondrosarcoma? And you mentioned osteosarcoma is one that is frequently in the mix there, but are there others that you see commonly? And does it make a difference in your treatment outcomes if it is diagnosed as one thing versus another initially?
Yeah, I guess the different types of chondrosarcoma that Bill mentioned are all in the differential diagnosis, as well as osteosarcoma. And then, it can also be the enchondromas, which are benign. Enchondroma can also sometimes be misdiagnosed as a chondrosarcoma and vice versa. That's my experience.
Yeah, I would agree. I mean, I think there's a lot of benign tumors, that can happen in the bone that need to be adjudicated. The enchondromas, the osteochondromas, can they be misdiagnosed? A lot of it also has to do with where the tumor may present. If you have a base of skull tumor, there's chordomas, right? There's other types of tumors that can develop in those areas. Sometimes you can even see reactive bone. If people have had a rib fracture, right, you can have a bone formation, cartilaginous formation. But, it's the nuances that John mentioned earlier, and why it's so important to have a certain level of suspicion. And have the right team kind of adjudicate what's going on, not only review of the pathology, but, often pathologists have to sit with the orthopedic oncologist and the radiologist, the musculoskeletal trained radiologist, to understand the nuances of how things look on scans, how they look on pathology review, the age and the story of the person who's presenting with the tumor, right? These are all critical. But yes, with rare diseases, there's a lot of different things that could mimic it, and ruling out, different diseases, different cancers, benign tumors are all very important.
Are there specific demographics that are more or less likely to get chondrosarcoma as opposed to a different sarcoma, or just in general? And then also, do you know of any differential outcomes related to age, location of the tumor, et cetera?
Yeah, It's a tough question again because of the heterogeneity of the diseases. And again, these are
Sure.
really rare, right? So, most people when they present with something, the first thought always is in a chondrosarcoma. So it's always hard demographically to try to find trends with it. But you can see, in my opinion, certain conventional chondrosarcomas happen in younger people. Definitely location can make a difference with prognosis, right? If you have larger conventional chondrosarcomas that are in the pelvis, they often require very big surgeries. They can cause a lot of pain and morbidity, like James spoke about. Having a tumor in a very difficult location, right, is very challenging from a surgical standpoint, because so many of these tumors, the main treatment is surgical, and that's very different than the dedifferentiated chondrosarcomas or the mesenchymal chondrosarcomas, where we don't necessarily always think of them as just a local problem, right? So, often why we'll think about chemotherapy as well. But there's tremendous variability in these tumors, how they present, how they affect people. And, with rare and ultra rare cancers, which they fall both into this, we have to learn from every individual, right? We have to understand every person who is dealing with these tumors, because collectively, that gives us enough experience to help guide care for everyone.
Yeah, I agree. And these, theoretically, chondrosarcoma can arise in any bone in the body. We usually see it in certain more common areas, such as long bones like legs, arms, the trunk. Those would be the most common. But head and neck does happen. And James' tumor, it sounds like, was identified somewhat incidentally, which is maybe a really good thing. There's
Yeah.
not we do see that with some of the rare tumors, the incidental findings, but the head and neck area, the pelvis, are a little more risky in terms of the surgery that needs to be done and the longer term outcomes. Larger tumors, more risky, and then the dedifferentiation, as we've talked about, is also a big risk factor.
Thank you. I'd like to pivot just a little bit and talk a bit about research around chondrosarcoma, both clinical trials-based research as well as basic science research. Could you speak a little bit about what is going on first in the clinical trials space, and what is going on there? Does it apply to all of the subtypes of chondrosarcoma? What's promising, and what patients can look forward to?
Yeah, I think it is an area, again, because of the collaborative nature of the community, and really the involvement of patient advocacy groups too, that are helping us think about ways to approach this disease. That there is a lot of research going on, as we mentioned early on. Understanding some of the genetics within these tumors is really important. So there's a lot of interest in understanding the IDH1 mutations, how that can potentially cause some of these tumors to develop. There's drugs against this IDH1 mutation and what it does in the cell, right? So that's something that's very interesting in people who have tumors, as to whether or not they'll benefit from these drugs. So that's an area of active research. I think as the conventional chondrosarcomas, which we're talking about, or I'm talking about now, as the tumors become a little higher grade, sometimes they get additional mutations, and we're beginning to understand those mutations as well, and what that means in how the tumors propagate. It also, I think, may suggest what treatments are available for people, so that's really important. There's also additional research being done in some of the dedifferentiated chondrosarcomas, where we've seen some efficacy of immunotherapy. So trying to fully understand that is really important. There's companies that have drugs that we're looking in, again, some of the conventional chondrosarcomas. There's the DR5 agonists, which are currently in clinical trials. So all of this is bringing in tremendous hope. I do think, though, the understanding a little bit about why these tumors develop, why some of them may transition into higher grades, understanding how they spread metastatically and why they would spread. These are areas that we really still need to investigate, right? But ultimately, if we can understand how these tumors are hurting people and why, like, those are the most important areas of research to say, let's try to tackle that, gain a better understanding, and then hopefully we can intervene at critical points in the tumor when they're really beginning to hurt people.
Yeah, that's great. And it is, at least I feel this way, Bill. It's, we're seeing some hope. We're seeing some excitement around the IDH inhibitors and the DR5 agonists. It's been a long time when we haven't had any treatments for conventional chondrosarcoma. So it's a very exciting time. And at least I feel like there's a lot of hope in the air.
Thank you. That's really helpful.
And then I guess for the lab, really laboratory, for any type of cancer, you really have to have laboratory models. And so to try a lot of different drugs until you find something that might be able to translate into a treatment for patients. And so there are a few animal models where the mice spontaneously can get chondrosarcoma from a IDH mutation that's in the germline of the mice. It takes a little bit of additional work than IDH alone, but it's a reasonable model that's led to some signs of activity. And then developing cell lines from patients' tumors. When patients have surgery, we try to collect their tumors and try to grow them in the lab so that we can have additional representation of populations. And develop different cell lines with different mutation profiles, whether it's IDH1, IDH2 that are mutated, or maybe neither. And there's other P53, there's TET, there's other genes that can lead to chondrosarcoma. And it's even different set of genes for mesenchymal and for clear cell and these myxoid and other types. But developing a model is key, because then once you have the model, cell lines, animals, or these groups of cell lines, groups of tumor cells together grown in the lab called an organoid, those are ways for us to test new treatments, whether it's a targeted therapy, an immunotherapy, or even some possibly revisiting some older chemotherapy, because we have so many new medicines in the oncology field that not all of them have been tested against chondrosarcoma. We think of conventional chondrosarcoma as chemotherapy resistant, but not every chemotherapy has been tested against chondrosarcoma. So there's still a lot of work to do, still more models that we need. But I feel like we're entering an era where there's some hope.
Yeah, I would agree. I mean, I'd also highlight that, there's tremendous advances in surgical techniques. There's tremendous advances in the types of radiation that are used. And we're seeing that applied a lot in chondrosarcoma. And just how quickly science is moving, especially with our understanding of how to process genomics, how to look at the protein levels within the cell and proteomics, or what's important with some of the IDH mutations, which is looking at what happens to genes after they're actually made into proteins, and how that all affects chondrosarcoma. So this is all moving so quickly. So how we unify this as a community, right? How we bring together collaborations, how we get enough patient samples to study with all of the different variations, I think is exceedingly important. And things that, behind the scenes, the International Chondrosarcoma, really inclusive of patients and patient advocates, are working on is really awe-inspiring.
Thank you so much. I'm going to start going through some questions that we've gotten from folks that are joining us today. And I'd like to remind everybody that you are welcomed and encouraged to please place your questions in the questions and answers field, and I will pose them to the panelists. I'm going to start with a question about a condition called osteogenesis imperfecta, which I imagine that you are familiar with. And the question is this one of the genetic conditions that is linked to chondrosarcoma? And if so, is that something that there's any research around? And can you speak to that?
Yeah, I mean, I can recall one patient that I've had with osteogenesis imperfecta who did develop a chondrosarcoma. So it is something that can occur. It's much lower probability of occurring than a germline IDH mutation like Olliers disease or Maffucci syndrome. Either one of those, there's a very high risk of getting a chondrosarcoma. They're generally low grade at initial diagnosis, so treating them with quickly and appropriately gives them just as good a chance of being cured as anybody who presents with a grade 1 chondrosarcoma without a hereditary syndrome. Osteogenesis imperfecta, there's a lot fewer patients with that hereditary entity that will develop a chondrosarcoma, but it is a possibility. Generally, with the hereditary syndromes that patients that we see in the sarcoma clinic here, we do at least an annual whole body MRI as a screening tool. It's not perfect, but it's probably the best thing that we have.
Yeah, I would agree with that. I mean, I think, both very rare presentations. There is, some case reports of it happening. We've all seen an occasional patient with it, but there's, not a very, very strong connection like we do see with Olliers or Maffucci's, where there's a higher preponderance to develop chondrosarcomas.
Thank you. I have another question here about another subtype. This is about extraskeletal myxoid chondrosarcoma. I think it was Dr. Tapp who mentioned that there's some question in the field about whether that's a true chondrosarcoma or not. And the question is, can you expand on that? And if not a chondrosarcoma, is there reason to think that they should be treated differently, or that a different type of specialist should be sought out? Can you expand on that?
Yeah, the extraskeletal myxoid chondrosarcoma is another tough disease. It's generally a translocation positive disease, meaning that one of the causative events is when two chromosome arms come together and bring together two genes that shouldn't be together, right? And one usually turns the other on, causing the disease. There's a debate, longstanding in the community about whether or not it's cell of origin is a a chondrocyte or a cartilage cell, which we don't think it is. And it's also a disease that has very variable presentations and courses within people. So, definitely a disease that should be treated at a sarcoma center of excellence where they're familiar with the disease, because there's a lot of nuances to it. And some of the treatments are vastly different than what we would think about when we think about some of the conventional chondrosarcomas or mesenchymal chondrosarcoma or dedifferentiated chondrosarcoma.
Yeah, I agree. It's generally falling out of favor as a true chondrosarcoma, very different than conventional. Often doesn't arise in bone, also mostly so. So it's probably not a chondrosarcoma and probably treated differently, but it's in the differential, so should be reviewed by an expert sarcoma pathologist.
Yeah, and there are conventional chondrosarcomas that have myxoid features, right? And they're often in the grade 2 conventional chondrosarcoma. So again, a lot of nuances. But why, having the sarcoma pathologist, the musculoskeletal pathologist to review, doing genomic analysis become very important, right? That really can help with the diagnosis.
I have a question about what you would suggest to a patient who either has a preliminary diagnosis of a chondrosarcoma or suspects that they may have a chondrosarcoma, and for whatever reason, whether it be financial, family, otherwise, is unable to get treatment at a sarcoma center, a center of excellence. They can't physically get there, they can't financially get there. What would you suggest is the ideal approach to get the best care in the absence of physically being at a sarcoma center?
Yeah, organizations like SFA are critical. Patients can get educational material from SFA, and it's important to have that information there. Talking with SFA and other chondrosarcoma patients through the support groups, and then we all in the sarcoma community have an open phone line to community oncologists. So Bill and I can't see every single sarcoma patient. It's just not practical. And I don't know what the recent data is, but it used to be somewhere around 50% of sarcoma patients make it to a sarcoma center of excellence. And I don't know what the current data is, but that's a lot of the sarcoma patients. And so we have open phone, open email. There's a sarcoma discussion group at ASCO that community oncologists can reach out to us anytime that they want to, and we're more than happy to share with them our opinion on the information that we have. We're limited by pathology review, which doesn't require a patient to physically travel, but the pathology material can be shipped to a sarcoma center and reviewed for a second opinion. That's always important step, as we talked about. And then once the diagnosis is really confirmed, Bill and I are happy to talk with community oncologists. We do it all the time.
Yeah, I would agree with that. I mean, I think again, it's a very tight community. Patient advocacy groups are wonderful in connecting patients with various sarcoma centers. You can think about one-time, telemedicine visits just so you can become familiar with a person. Pathology review is critical, and a lot of times the community oncologist can actually trigger that, so it gets done. So you make sure that you have the right diagnosis. And I will say, being an advocate for yourself is really important. And, most community oncologists are honest in saying, we don't see this all the time. So, we're going to reach out to someone, or having recommendations of who they can reach out for, or even creating that level of contact is really important. But as John said, I mean, every day we get multiple emails where we're talking with community oncologists, we're talking with patients, we're talking with surgeons to try to offer people best care with all the information we have. So there's a lot of information out there. There's a lot of connectivity, and be it because of location or finances, that doesn't necessarily mean that you won't be able to get connected to some of the experts in these diseases to really understand how to help with treatment. That's really what we're here for.
Thank you. That's really helpful. That's something we want to encourage all patients to consider, that there's ways to get treatment, or at least get opinions from experts, even in the absence of being able to get to a sarcoma center. So thank you for that. Another question, and probably one of the last few given our time, what would you consider to be one of the biggest hurdles in research right now, either in clinical research or basic science research? I know I'm asking a very poignant question, but would love to hear your perspective there.
Well, sarcoma is a rare disease. There's 175 or so different types, and chondrosarcoma is one of the types, and it's an important type that Bill and I both spend a lot of time in research and clinical trials and patient care and education. But it's not like it's a public nuisance. It's not like it's like the number one in the nation or in the world in terms of impact on lives. And so because it's so rare. So it's not always easy to get funding for our trials, interest from pharmaceutical companies, funding for our laboratory research. That's all a bit of a challenge because it's not like it's breast cancer or prostate cancer. So we do face those hurdles, and also drug development. It's pretty excited right now about the new drugs, and that some companies are willing to take a risk on drug development in a rare disease, but we don't know if that'll continue. So support from the chondrosarcoma community, from SFA, continuing to support and contacting the government, the NCI, pharmaceutical companies about continuing chondrosarcoma research could help.
Yeah, I would echo that 1,000%. I mean, you know, we could talk about, you know, cuts in NIH funding and, you know, what's happening and how that affects cancer research in general. But I think ultimately, you know, what SFA deals with, what John and I deal with, are rare and ultra rare cancers, right? So we need to band together as a community so that we are all studying the most important questions. We're all doing it together as a team. That we are learning from every patient, that patients are involved because their voice matters, because every step we take is critical in that we take the right step, right? That's really what's important about this. And you know, often the most challenging things, we're forever talking to regulatory bodies in Europe and in the US, and how we can have special circumstances for drug development in rare and ultra rare cancers. We're trying to understand how diseases like chondrosarcoma that present in multiple parts of the body and can be difficult to shrink when we treat them, just because of that cartilaginous matrix, that we can identify symptoms or clinical outcomes that are important for patients, right? So that we can develop drugs correctly. We're trying to get enough samples so that we can understand the nuances and the diversity of the diseases, right? And ultimately what it comes down to is that we want to affect this disease in a way that's important to the people who have it, right? So that's where the people's voice comes in. That's where James's experience is so critical. Because if we can't do things that are immediately important for people, right, then we're often working in the wrong area. But because it's a rare and ultra rare disease, you know, what we work on is critical. So having that consensus and being empowered to do that, I think is the most important component of this.
Thank you so much. That's great. Thank you so much. Okay, so we are about at time, so I'm going to go ahead and wrap us up for this evening, unless anyone else has any last minute questions.
Could I just say one more thing?
Absolutely.
So participation in clinical research is really important to the community. And there's not necessarily in chondrosarcoma, but there's data to support the fact that patients on clinical trials have better outcomes than those not on clinical trials. And there's currently a clinical trial for chondrosarcoma. It's an IDH1 inhibitor. It's open at our institutions and multiple institutions around the world. And if you or you know somebody with a newly diagnosed chondrosarcoma, or a chondrosarcoma where you need some type of therapy throughout the body, please reach out to one of us and let's discuss the benefits and risks about participating in the IDH1 inhibitor ivosidenib clinical trial.
Thank you. Yeah, there's also information about that trial on SFA's website. So you can also reach out to us and we can put you in contact with a sarcoma center close to you or a site that's available for you. So thank you for bringing that up. That's wonderful. All right. Okay, so at this time will conclude our session for this evening. Thank you all for taking the time to be with us today and sharing your expertise and experiences respectively. We appreciate all that you do for the sarcoma community. And thank you to everyone who logged in today to be a part of this important discussion. As a reminder, today's session was recorded and a link will be posted to SFA's website within the next few days at curesarcoma.org, as well as emailed to all registrants. This now concludes the discussion for this evening. Thank you.
Thank you.
Thank you.
Thanks.